I can hardly believe that I'm giving this talk today. Usually at program science symposia, I talk about the concepts or the general approaches or what we should be doing. But today I can talk to you about what we have done in the United States, which gives me great pleasure, of course. So my presentation is titled Program Science in Action, Observations, Reflections, Recommendations around the United States, STD APPS. APPS stands for Assessment, Assurance, Policy Prevention Services. That's the title of our most recent funding opportunity announcement that we put out in June 2013 to fund the STD prevention programs in the country. This happens every 5 years. We come out with a new FOA. We tell the prevention programs in the states and a few big cities, we tell them, we're giving you all these monies, which the Congress gave us to give you, but in return, we expect you to do the following activities. Well, this time around, in June, we published the funding opportunity announcement. The cycle starts in 2014, January 2014. And this funding opportunity announcement looks nothing like earlier funding opportunity announcements we put out, because it structures the United States STD prevention program completely on program science principles. And what I'm going to do today with you is to share with you my observations as well as reflections and recommendations around this change. So resource allocation clearly is a major focus of program science. And as we went through this funding opportunity announcement change and preparation, we found that resource allocation in the United States has not been the way it should have been. Resources have not been allocated with any attention to morbidity, population size, or program capacity. So we came up with a new formula for resource allocation. And the new formula takes into account morbidity, looking at both numbers of cases, absolute numbers of cases, and case rates in states and the large cities. It takes into account program capacity, and it takes into account population size. And contrary to all expectations, we had no major negative reaction from grantees and potential grantees to this change in funding formula. So in the future, I think it may be very important to include in our surveillance plans a continuous monitoring of resources, of cases, case rates, and program capacity, and to systematically follow the relationship among these things. Apparently, in the past, we just pretty much gave the states and the big cities whatever they expected us to give them. Whether or not they did anything with the monies, whether or not they had the need reflected in morbidity, seemed to be irrelevant to our actions. Secondly, prioritization is a major focus in program science, and it involves prioritization across key risk populations, such as men who have sex with men, adolescents in the United States, this is an important key population, minorities, and key geographical areas. Given how much concentration there is in morbidity as well as in risk behaviors, it would be difficult to expect any programs that do not prioritize to be successful in their STD prevention efforts. So in the United States, of course, we find great variability in the extent to which program areas engage in prioritization. Most areas prioritize minority populations. For us, that's African Americans or Black populations. However, when you start looking for prioritization of men who have sex with men or prioritization of adolescents, that's observed only in a very few areas. Prioritization in response to geographical concentration is even more heterogeneous. We do have some programs, some model programs. For example, in San Francisco, in New York City, and in Seattle, they conduct systematic geomapping of their cases and their case rates, and they do focus programmatic activity accordingly. But in other areas, not so much. We don't see it. So towards the future, it may be important to encourage and perhaps even require grantees to geomap their cases and their case rates, and to adjust their programmatic plans to the geographic or spatial distribution of their cases and case rates. The STD apps, the new FOA, strongly encourages program areas to use geomapping, and as time goes on, I think we will urge them to do this more and more strongly. Third, program science emphasizes the need to implement evidence-based interventions and to take into consideration the interactions among interventions, such that between interventions, synergies, antagonisms, and overlaps can be noted and planned for and reacted to. Well, when we looked at the available data, what we found is that there had not been a systematic guidance to the programs regarding available scientific evidence supporting specific interventions. There have always been scientific publications showing efficacy of interventions, but those scientific publications had never been pulled together, synthesized, translated in guidance to program areas. We are now in the division developing this guidance. It will be available on our division website for all programs, and we will actually conduct all kinds of webinars to get the guidance to the program areas. So then, when you look for guidance regarding synergies, overlaps, and antagonisms among interventions, of course, that's a totally different story. To my knowledge, I don't think we have the scientific data to support the development of such guidance. So with respect to those interactions, I think we are at an earlier stage. We yet have to develop the scientific data, the scientific evidence, and then next we will be looking at the development of the guidance. So I believe this lack is a direct result of our tendency to look at, to think about interventions individually in isolation, rather than considering them to be components of an integrated whole, the program. This approach, of course, has important implications for our cost-effectiveness analyses as well. Usually, when we do cost-effectiveness analyses, we consider interventions as if they are happening in a vacuum. We look at the impact of an intervention and we ask the question, how much does this cost? Whereas we are hardly ever introducing a new intervention to a vacuum, especially in a country like the United States, and I would assume the same holds for Canada. It's hard to imagine that there would be any community where there isn't at least some interventions to prevent STD spread and HIV spread. So we're never introducing an intervention into a vacuum. We should never be talking about absolute impact of an intervention or the cost effectiveness of an intervention. We should be always talking about marginal what's the other word I'm looking for? Incremental or marginal impact, incremental or marginal cost. Actually, I think Sharmista has some very nice modeling work she has done, looking at incremental impact and incremental cost effectiveness. So maybe later during the discussion session, we can learn from Sharmista. Actually, apparently, I raised this issue with our health economists in the division, and they very much agree with me that this kind of approach to cost effectiveness is highly misleading. And they also informed me that this is particularly problematic with respect to cost effectiveness analyses of HIV prevention, globally. So we are doing some focused work in the division in this area. So future research, I think, will be needed looking at interactions among interventions. We need both empirical studies and mathematical modeling to look at synergies, antagonisms, overlaps, as well as issues of marginal impact and marginal cost. So, program science also emphasizes the importance of context. Just as interventions interact with each other and may have additive, synergistic, or antagonistic effects on each other, they interact with the context they are introduced into. In fact, the impact of interventions, whether or not they work in a particular environment, is very much a function of the interaction between the intervention and the context it's introduced to. Better still, I think intervention impact is a function of the interactions among the intervention in question, the other interventions which are already in place, and the remainder of the context. So situation analyses, rapid assessments, and gap analyses may be used to arrive at a systematic description of context, and then we would periodically have to update that context description. In the United States, we find that a few STD prevention programs are knowledgeable about their population context, but there are only a few such programs. So during the first year of the STD apps, the first year has already been declared a planning year. So during this first year, the scientists in the Division of STD Prevention will work very closely with our grantees to conduct context assessments and to make them knowledgeable about their population and community context. We will help them do rapid assessments and gap analyses. And we have already initiated a pilot gap analysis project, which is being fielded in North Carolina as we speak. In fact, as soon as I go back, we will be analyzing the results of the pilot project. Now, we can do context assessments through a variety of approaches. We can do key population mapping, which University of Manitoba has been really great at. We could do geomapping of services. We could look at the joint distribution of key populations and services that they may need. In describing context, we could do all kinds of attitudinal assessments. But it will be very important to develop comprehensive context assessment tools and make them available to our grantees so that they can conduct their own context descriptions. As part of context assessments, it's necessary to identify which services are already being provided to which populations, at what quality, and what coverage. Program science would highlight such information as an important component of program planning. What do we find in the United States? We find that programs in general are informed about the services they themselves provide to their key populations. They tend to lack knowledge of services being provided to the same populations by other agencies and organizations. I think this results, again, from our tendency to see health agencies as individual entities operating in a vacuum rather than as components of an integrated health system. As we move into 2014 apps implementation in the STD prevention arena, division scientists will need to work with STD prevention program staff, particularly during the first year of funding cycle, to help conduct health system descriptions and establish system perceptions among STD prevention staff. Unless people start thinking about the whole system, I don't think we'll be able to really implement a program science approach in the country. So program science also, I think Jamie mentioned this, emphasizes the important role embedded scientists can play in the planning, implementation, monitoring, evaluation, and most importantly, tweaking of prevention programs. In the United States, we find that several STD prevention programs have embedded scientists. A great majority of programs do not have such people on their staff. The existing embedded scientists are all medical epidemiologists. I don't think this is necessary. I think PhD epidemiologists, demographers, anthropologists, geographers, and other specialties may be able to function as embedded scientists. Moreover, to me, it's not clear that doctoral level training is necessary to function as an embedded scientist. People with master's degrees in public health, if trained properly, may be very helpful in this capacity. This is a huge discussion in our division at this point in time. We believe very strongly that we need to focus on the creation of a fit-for-purpose public health workforce. So we are planning very specifically to work with schools of public health towards this end. We're already developing a list of programs indicating whether or not they have embedded scientists. And we have started talking to schools of public health about creating training in program science. Exactly what shape that training will take, I think, is still up for grabs. And we look very much forward to working with people in Canada who are trying to implement program science approaches in the creation of this capacity development activity. Finally, program science is a continuous approach. It's a continuous discipline. It refers to a continuous cycle of data assessment, planning, implementation, evaluation, followed by tweaking, and you start all over again. I have presented to you my observations and thoughts at this point in time as we are poised to start the first year of our STD Apps program. Obviously, as we go along, I will have other thoughts. I may discover I was completely wrong in my assumptions or observations, so please stay tuned. I hope I will be updating you in future meetings. But I've had some afterthoughts. You know, this tendency to think of interventions and health service agencies individually, the tendency to disregard context, and the tendency not to pay attention to linkages and interactions has been disturbing me tremendously. So one thought I have is we really have to focus on this and figure out ways we can help our program staff start thinking in systems terms. But I have also been doing quite a bit of reading. Why is this happening in STD prevention? Why are we stuck in this, to my mind, less evolved form of thinking? And I discovered that it's not, these tendencies are not unique to STD HIV prevention programs. Apparently, there are quite a few very heterogeneous experiences that have been happening that are attributed to this tendency to think about things as isolated individual events and to disregard context and to disregard interactions among events. For example, the collapse of Jamaica's reefs and related loss of fish supply in 1983 is explained as a failure of systems-level thinking. Similarly, the devastation of California's sardine industry in 1950s is explained as a failure to engage in systems-level thinking, and as a result, not taking the precautions that needed to be taken as the environment was changing. The recent global financial crisis is thought about as a result of a similar failure, a failure to look at the linkages and interactions among events. Sugihara is apparently a very prominent systems thinker in the field of ecology. And he says, we like to see the world as consisting of separate parts that can be studied in an isolated, linear way, one piece at a time. It's a case of looking under the lamppost because the light is better, even though we know the keys are lost in the shadows. I had to share that quote with you, because when I read it, I almost got tears in my eyes. I'm sure Jamie has heard me say, maybe not exactly these words, but I'm sure he has heard me say many, many times, it's like looking for the keys under the light, rather than looking for them where we lost them. And I'm sure he has heard me say many times the same thing in the first sentence. People like to look at the world as consisting of separate parts. People like doing linear thinking, one piece at a time. It's always wonderful when somebody else says what you have been thinking along the way. And all of this I have read in this book called Resilience by Andrew Zolli, Resilience, Why Things Bounce Back. He talks a little bit about personal level resilience. Most of the book is about resilience of systems to bounce back. I think I'm studying the book. I guess I am recommending it to you. I think we really are gonna need resilience thinking more and more as we go along, particularly with the financial crises and all of the other types of crises we are getting into. So we do need to move to systems thinking, but this is very difficult to do. With program science, we have been trying to do this for a long time, and I think it's difficult to accomplish. What do we do about that? Well, one thing we have done is we have taken the first step for a United States-Canada program science collaboration. We actually came and had a visit with Public Health Agency Canada, talking about how we can create a collaborative network and how we can move together in program science approaches to at least STD HIV prevention, but probably in other areas as well. There is also the Countries of the North Program Science Network that Jamie mentioned, which includes not only Canada and the United States, but also Europe through the European CDC, and the United Kingdom through, what are they called now? Public Health England, and Australians are very interested in this. And finally, we are trying to bring systems level thinking to all of our publications and to all of our meetings. And the first trial of a meeting with systems level thinking is going to be the 2014 STD Prevention Conference. This will take place in Atlanta from the 8th of June through the 13th of June. Please mark your calendars. I already know quite a few Canadian public health experts are going to be there. We would love to have all of you there. We are looking forward to a major World Bank presence and a lot of symposia and workshops on program science will be there. So hopefully that's going to happen. Finally, I am hoping while I'm here, there will be a lot of discussion on training programs with centers of global public health, with schools of public health. I would love to know what Canadians are thinking about this workforce development idea. And it would be great if we could collaborate because there aren't all that many centers of excellence in this kind of thinking in either the United States or Canada. So we could learn a lot from each other, and we could have our public health our public health programs collaborate with Canadian academic institutions and vice versa, I think. So I'm going to stop there. Thank you very much.